Okay, thank you, and good morning. Thank you for participating in today's media briefing. This is our 32nd since the start of the pandemic. We continue to hold these briefings as part of our commitment to provide timely and accurate information. Today I'm joined by Dr. Derek Angus, UPMC's Chief Innovation Officer, Dr. Rachel Sakrowitz, the Chief Medical Officer of UPMC's ICUs, and Dr. John Williams, Chief of Pediatric Infectious Diseases at UPMC Children's Hospital. They will share the latest findings from UPMC's innovative learning while doing COVID-19 trials and provide an update on our continued preparedness to treat COVID-19 patients and all patients at our hospitals and facilities. After their remarks, we'll take your questions. Dr. Angus.
Thank you, Paul. At the very beginning of this pandemic, UPMC saw that the old way of doing academic medicine wasn't going to work. And by that I mean the slow, traditional clinical trials that give half of the participants a placebo and plod along until results are published often years later in peer-reviewed academic journals. Instead, what we saw immediately was that patients with COVID-19 were, of course, desperate for any possible therapy, and their doctors need immediate answers. And so in the early spring of 2020, we launched our REMAP COVID-19 trial, a platform trial that could give all of our patients the best COVID-19 therapies in a coordinated way. That's helped us to learn at unprecedented speed how to best take care of COVID-19 patients. Some examples: we found that inexpensive steroids help the sickest hospitalized patients and even reduce their odds of death. We found that blood thinners are also incredibly important in helping the moderately ill hospitalized patients. We helped settle the debate that hydroxychloroquine simply didn't work. And more importantly, we really showed that UPMC was transforming into a rapidly learning health system that changed clinical practice as soon as we had evidence-based discoveries and brought those discoveries to all of our patients across our entire system. And so in many ways, the biggest win has really been for our patients. Over this epidemic, of the 11,400 hospitalized patients that we've had with COVID-19, the odds of death has been falling by 5% every month. Still, we're not satisfied. And if you get COVID-19, we want to keep you from ever needing hospitalized care. So in February, we partnered with the White House COVID-19 response team, formerly known as Operation Warp Speed, to vastly expand the clinical use of monoclonal antibodies. This one-time treatment, if given within about a week of COVID-19 infection, significantly decreases the risk of hospitalization and of death. And yet, at the start, few patients who were eligible, either here or anywhere across the United States, were actually receiving monoclonal antibodies. And so within 3 weeks of our conversation with the White House, we had already launched our optimized C19 trial of monoclonal antibodies, starting with monoclonal antibodies provided from Regeneron and from Eli Lilly. We wanted to quickly learn which of these antibodies was best for our patients. And so far, this trial has already shown us that the best monoclonal antibody has been the one that's available to you. In other words, the treatments that we've compared so far look very similar to each other, and they're safe, they appear equally effective. So we're now collecting real-time data inside this same trial, this same learning platform, on how the currently available treatments, still from Regeneron and also from GSK, perform against the Delta variant. We've already enrolled over 4,000 patients in optimized C19, and it's helping us to create the scientific knowledge that will serve not only our patients, but contribute to knowledge for the rest of the world. Since the start of this pandemic, we've treated now 5,700 patients with monoclonal antibodies. That's 2,300 more than just a month ago. Those are patients who are mostly kept out of our hospitals. it looks like as many as 70% of the patients that would have been hospitalized are now avoiding hospitalization if they get monoclonal antibodies. So if you get COVID-19, UPMC is here for you. We don't want to put you in the ICU or even in a regular hospital bed. We will if we have to, but what we want to do is to keep you out of the hospital altogether. And so please help us, first, by taking the vaccine. Second, by wearing a mask. Third, keeping distance when indoors. And fourth, if you get sick, isolate, but get tested promptly if you have symptoms. And if you are positive, ask so that we can check if you are eligible for monoclonal antibodies. Thank you.
Thank you, Dr. Angus. Delta, the SARS-CoV-2 variant dominating our communities, is different than what we've seen before. It's pervasive, it's more easily spread than the original virus, and it is just as deadly. Delta is spreading amongst people we previously considered less vulnerable. We are seeing a truly alarming number of healthy people in their 20s, 30s, 40s, and 50s being admitted at UPMC and becoming critically ill, needing ICU care. The average age of our hospitalized patients is almost 10 years younger than when we were at the peak of last winter's pandemic in December of 2020. This is concerning because these are people who have few other health issues and would otherwise be looking forward to many healthy years ahead. But the overwhelming majority have one thing in common. They are not vaccinated against COVID-19. If you are not vaccinated, your risk of being hospitalized with COVID-19 is 29 times higher than the risk of someone who is vaccinated. Over the past several weeks, we have seen as much as 19 times more unvaccinated patients ages 50 and younger admitted to UPMC hospitals compared to vaccinated patients. As we fight this pandemic, we and the entire community continues to ask an incredible amount of our employees. Time after time, they step up, but this has been a grueling and incredibly heartbreaking 18 months. Since COVID-19 first hit, our UPMC employees, just like all other healthcare professionals across the globe, made countless sacrifices. We were flexible, we were brave, we picked up additional shifts and worked long hours, and we sacrificed time with our own families. We did everything possible to deliver the world's best care to our patients and communities. We saved countless lives, and we suffered the excruciating loss of so many others. And now we're experiencing this trauma all over again. And what makes this wave particularly heartbreaking is that it was largely preventable. We have 3 highly effective, free, safe, and widely available vaccines. They all dramatically reduce the severity of illness and the number of hospitalizations, ICU admissions, and most importantly, deaths. Breakthrough cases of COVID-19 in vaccinated individuals are rare. And when one does occur, that vaccinated person is fighting a bad cold at home instead of fighting for his or her life in the hospital. What makes this wave particularly challenging is the current ongoing national nursing shortage and its impact on our ability to increase capacity. UPMC is in a better position than many, given our size, resources, and ability to spread the burden across our large healthcare system, as well as the initiatives we can give our nurses, like flexible shifts and generous overtime. But we are still stretched. My urgent plea is for everyone eligible for a vaccine to make the choice to get one. You aren't just getting this vaccine for yourself. You are doing it for those around you, your parents, your children, your neighbors, your coworkers, and the doctors, nurses, respiratory therapists, and all the other healthcare heroes who continue, after all these many months to work countless hours to save lives. If you are unvaccinated, please reach out to healthcare providers who can address your concerns, or come to our vaccination clinics. Even if you don't want to be vaccinated that day, our experts will respectfully answer all of your questions. Most importantly, we have the power to defeat this and collectively get back to our lives. We have seen incredible progress since the start of the global pandemic. By working together, taking care of ourselves and each other, and taking the kind of actions we know are effective: vaccination, masking, and early treatment, this virus will have met its match. But we won't be successful without your help. Thank you.
Thank you, Dr. Sakrowitz. Speaking as a parent of 4 and a pediatrician, I have to note that we're in a particularly risky phase of the pandemic for children, many of whom, less than 12, are too young to be vaccinated. Unlike what many have heard, children do get sick with COVID, and they can transmit the virus to family, friends, and other members of the community. At UPMC Children's Hospital of Pittsburgh, we are seeing an increase in outpatient cases of COVID of children in the clinics and the emergency department, and an increase in children hospitalized with COVID. It's nowhere near as bad as some of our colleagues around the country or some other children's hospitals, but we don't want to get that bad. And one of the key ways to not get that bad is to protect our children with masks and vaccines. An important thing to remember, as Dr. Sakrowitz mentioned, is that children under 12 are too young to be vaccinated, and a key way to protect them is for those over 12 and their parents to become vaccinated. These young children are at a higher risk for becoming infected now than at any other time during the pandemic, and that's for 2 reasons. One is relaxing of mitigation, and the second reason is the Delta variant. As Dr. Sakrowitz mentioned, the Delta variant is more contagious and more easily spread, and it's circulating everywhere in the U.S. right now. Fortunately, we know how to keep kids safe, and some of these tools are the same tools that we've been using for the past year and a half: masking, vaccination, and testing. We know that masking and distancing are very effective at reducing spread in the healthcare system, in the classroom, in the rest of our lives. With schools reopening, we need to ensure that we meet children's educational, developmental, and social needs while keeping them as safe as possible. For that reason, the UPMC Children's Hospital of Pittsburgh strongly supports the CDC and American Academy of Pediatrics guidelines to keep children safe in school, including universal masking in school of vaccinated or unvaccinated people. The second tool is vaccination. As mentioned, we have 3 safe and highly effective vaccines that have been shown in large scientific trials, as well as the administration to hundreds of millions of people. They are safe and very effective, even against variants like Delta. An important thing for children is that vaccination also protects those young children who cannot yet get vaccine, or people who are vulnerable and immune compromised who may not fully respond to vaccine. An important fact that highlights this is that if we look across the U.S., in states where vaccination rates are low, hospitalizations of children are 4 times higher than in states where vaccination of children is high. And secondly, of children eligible for the vaccine from 12 to 17 years, unvaccinated teenagers are hospitalized 10 times more frequently than vaccinated teenagers. The third component of managing COVID in children is testing. Testing is widely available and remains a very important tool. If you or your child have fever, cough, other respiratory symptoms, contact your pediatrician to see if they should be tested for COVID. This testing is available in the outpatient setting or for our emergency department and inpatients. I want to close by noting that, as mentioned for adults, most children who are getting sick and virtually all the children who are getting hospitalized are unvaccinated children. And while many have comorbidities of other underlying medical conditions, many of them are otherwise healthy children. So I would plead with you as a pediatrician and parent, let's all do our part to keep our community safe, especially children, during the pandemic. Thank you.
Okay, thank you, doctors. So in summary, we're showing you a slide that has some of the key data points that Doctors Angus, Sakrowitz, and Williams just chatted about. And we're going to leave this up very briefly and for you to look at, and we'll post it to our newsroom so that you have it to use in the stories you're creating. Now we'll take your questions. Again, as usual, go to the participants icon at the bottom of the page and press the raise your hand button. That will put you in our queue. I will read your name and unmute your line for you. Please remember to unmute your microphone on your end, and we will call on as many different media outlets as we can. So again, press the raise your hand icon to be put into the queue. First question, Dr. Williams, you talk about school children still wearing masks. When will this pandemic end?
Well, that's a great question. Thank you. You know, we really have the tools to limit or nearly end this pandemic now, and the primary tool would be vaccination. We have 3 safe and highly effective vaccines, and if most of the population were vaccinated, then adults wouldn't be getting sick and going to the hospital, children wouldn't be getting severely ill and going to the hospital, and the spread would be drastically reduced. Yes, breakthrough infections happen in vaccinated people, but they're very rare, and as Dr. Sakrowitz noted, they're generally very mild. So the best thing any of us can do to end the pandemic and get all of our lives and our kids' lives back to normal is that everyone who is eligible should be vaccinated.
Thank you. First question, Paul Goff, Pittsburgh Business Times. Paul, please go ahead.
Hi, thanks for holding this briefing. Two questions. One, are you seeing an increase in hospitalizations among kids due to the start of the school year and sort of the different masking policies? And then second, do you expect to see and when a decline in those cases due to the mask mandate that was put into effect yesterday?
I didn't hear the second part of the question.
Because the school year started, and then do you expect to see a decline because of the masking mandate?
Yeah. So while we are seeing an increase in our region in cases, it's not yet dramatic. We hope to prevent that. It's too soon to say if it's related to kids going to school, and as you know, some districts were unmasked and some were wearing masks. As I mentioned, UPMC Children's Hospital supports the CDC and American Academy of Pediatric guidelines. I will say the national data make it very clear, and talking to my counterparts in children's hospitals in states where vaccination rates are much lower and infections are much higher, there is no question that a lot of kids going to school unmasked is contributing in a major way to the spread of COVID in children and to hospitalization in children in these states with low vaccines and low mask wearing.
Okay, thank you. Next question, Liz Kilmer, WPXI TV. Liz, please go ahead.
Hey, thanks so much. So I apologize if this was addressed. I did lose the feed momentarily, but are monoclonal antibodies being used to treat children? And then what additional treatments are being used to treat kids? And then can you talk specifically about the antibodies, the monoclonal antibodies, and their success with the Delta variant specifically? Thank you.
Go ahead, Derek.
So monoclonal antibodies are not being used for children right now, although I'll pass over to John to provide caveats on that. As far as Delta is concerned, so that's why we are formally testing to ensure that the different options available all work in Delta. That's a specific objective of our Optimize C19 program. There are 3 monoclonal antibodies that are believed to work in vitro, sort of in a petri dish. And so those are approved under the emergency use authorization by the FDA. That's from Regeneron, from GSK, and from Eli Lilly. And all three are being evaluated and used by UPMC. Was there another part to your question?
I think it's John about children, using monoclonals in children.
Yeah, so we are using monoclonal antibodies in children over 12 years of age in whom they're approved, and we've treated several dozen. To the point about the escape of Delta, this again highlights the strength of vaccination. So monoclonal antibodies, each one is like a single bullet. As Dr. Angus mentioned, they are used as a cocktail of several bullets. But it's a lot harder to escape from a swarm of antibodies from vaccine. That's more like a shotgun blast. And all the vaccines remain very effective against Delta and the other variants.
Thank you. Next question, David Winter, Harrisburg Patriot News. David, please go ahead.
Thank you. This question is for Dr. Angus. In light of what you said about the REMAP study and the conclusions you reached about various medicines, including some repurposed medicines, does ivermectin figure into that mix? And are you even allowed to study it or try it? How does it fit in among the possible things that might help?
So, ivermectin grabbed some attention from non-randomized trials, but there's already been one pretty large and convincing trial that showed no benefit from ivermectin. We are not using ivermectin routinely at UPMC. There are some ongoing discussions among trials groups around the world, including part of the REMAP consortium, about whether we would consider doing further evaluation of ivermectin. But in general, I would say that we, along with most other scientific bodies, are not incorporating ivermectin as a recommended treatment.
Thank you.
Okay, thank you. Next question, Bill Kibler, Altoona Mirror. Bill, please go ahead.
Thanks very much. I guess I have a sort of a two-part question. Can you say how rare breakthrough infections are, and how often do vaccinated people need to get tested? Every time they get a sore throat or a sniffle or a cough?
Dr. Williams.
Well, overall, breakthrough infections are very rare among vaccinated people. It's been estimated 1 in several thousand. However, even vaccinated people, if they're in close, unmasked social gatherings, parties, bars, things like that, they can be infected, especially with the Delta variant, which is more contagious. Now, as Dr. Angus and Dr. Sakrowitz mentioned, vaccinated people have much milder disease if they do become infected.
Thank you. Next question emailed to us is for Dr. Sakrowitz. You described the toll this pandemic has taken on the nursing staff. What is UPMC doing for its nurses and other clinical caregivers?
Yeah, thanks for that really important question. Before I answer that, I just want to start again by acknowledging the incredible demands, the unthinkable demands this pandemic has placed on our entire nation's nursing team. It has taken an enormous physical and emotional toll. At UPMC, we initiated a Focus on Our People program with the goal of incentivizing our own team before turning to outside agency or other resources to meet new needs. And this program has been very successful. It includes components such as premium overtime, incentives for those who are willing to consistently pick up additional work, a competitive pay differential, flexible scheduling, so that the work schedule can be more consistent with our employees' needs. And our health system demonstrated our commitment to our employees during the pandemic when we had low patient volume and refused to cut pay or positions or benefits. So this program has been very successful. We've been able to fill thousands of open shifts with our own team instead of turning to outside agency or other triage methods. But our team needs more than incentives and pay. Our team needs us to end this cycle of COVID surges and hospitalizations. Our team needs the time and space to heal and rebuild and regroup. And you can help by putting on your mask and getting a vaccine if you haven't already done so and are eligible.
Thank you. Next question, Lauren Rosenblatt, Pittsburgh Post-Gazette. Lauren, please go ahead.
Hey, thanks for taking the question. I had two different ones. First, I was wondering if you could share any specific numbers about the number of cases in children. I know you said there was an uptick and it wasn't dramatic, but can you share anything about hospitalizations, outpatient, et cetera? And then my next question was about the policy, UPMC's policy for vaccinating workers and if there is any plans to make it mandatory.
Start with Dr. Williams.
Yeah, I can take the pediatric part. So we are seeing, I would say, a modest increase in the numbers. We're not releasing specific numbers on a routine daily basis due to privacy concerns of the families and the children involved. But we are seeing a modest increase in all three of those settings: outpatient clinics, emergency department, and the inpatient setting, including children in the ICU.
I could address the second part of your question. So we believe that vaccination is our most powerful tool to end this pandemic. And we believe that everybody who is eligible should be vaccinated. We also know that it is safe for unvaccinated healthcare workers to deliver care to patients. And we know this because we did this for the first many months of the pandemic before vaccines were available. We know that patients are safe in our hospitals and offices regardless of the vaccination status of their provider. So we are focusing at this time on communication, on staying in dialogue, and on building trust. We're exchanging information about vaccine safety and efficacy so that we can resolve any vaccine hesitancy that remains on our teams and together end this pandemic. We reevaluate our approach every day.
Thank you. Next question, Brett Solstice from WITF FM in Harrisburg. Brett, please go ahead.
Thank you so much for your time, and hopefully you can hear me okay. Regarding the monoclonal antibodies, with the understanding that many of the same people who might be needing to get them now are also people who are anti-vaccination, anti-mask, and deeply distrustful of the medical establishment, can you give them a sense of what to expect, how safe it is, how soon after their positive test results they should get it, and I think I know the answer to this, but what it might cost them?
Dr. Angus.
So monoclonal antibodies work best the earlier they're administered. So as soon as you have symptoms and turn PCR positive, we want to hear from you so we can assess your eligibility. So in terms of timing, it would be as soon as possible. In terms of how safe they've been remarkably safe. And not only in the original trials have any adverse reactions been very, very rare, but in our experience with several thousand cases, we've had just a handful of mild adverse reactions, not uncommon really from receiving any other medication. So we have found them to be remarkably safe and remarkably effective, and we want to give them to those who are eligible as soon in their course as possible. That will result in the most efficacy. They are we can get back to you on the exact details, but they're essentially well covered by insurance plans, and so they're the cost to an individual patient, we will clarify, but it is very minor, if not in fact completely
Cost
free.
of the drug is zero.
The cost of the drug is completely zero, and indeed supplied free of charge by the government and by the drug providers.
Dr. Angus, can you speculate on why someone would trust the science behind monoclonal antibodies but not trust the science behind vaccines?
So, one important thing about the monoclonals is that they're tested in patients who are sick. The only patients in those trials are the patients who already had COVID. And then they were measuring very, very concrete outcomes. Like if I gave these few thousand patients monoclonal and I didn't give it to other people, how many people get hospitalized or die in the next month? And the answer is far fewer with monoclonals. These are absolute, incontrovertible, very transparent, concrete trials. The reason for vaccine hesitancy is complex, and there may be many factors entering into it. But the monoclonal antibody trials are very solid, traditional looking trials. The evidence behind them looks like the evidence we have behind many of our best drugs in any other disease.
Thank you. Next question, Nicole Brambilla from the Lancaster Online. Nicole, please go ahead.
Thank you so much for taking my question. As you're likely aware, Penn Medicine and Lancaster General Health in Lancaster specifically implemented a mandatory vaccine for staff back in May. And at that time, UPMC said that system-wide, your staff vaccination rate was roughly 70%. And last I checked, it was still 70%. I have 2 points of questions. One is what is the vaccination rate today? Why isn't UPMC providing it at a local level? Because I think folks at UPMC Lidditz, for example, would care to know if the rate is higher or lower than that. And, what kind of responsibility do you have to be transparent to patients who might be concerned to know whether the person they're interacting with is actually vaccinated or not?
I could start, and maybe other people will weigh in. Our vaccination rate at the system level is 70%. It varies in our individual hospitals, and while I couldn't tell you that off the top of my head, any patient can ask their provider whether they've been vaccinated and expect an honest answer. We spoke about the reason why we are focused on communication, on sharing information, and building trust with our team so that everyone will choose to get vaccinated. And you mentioned that the rate in Lancaster hadn't changed with mandatory vaccination. And that is why right now our strategy is what it is, to educate, to talk, and to communicate.
Okay, thank you. We have a follow-up question from David Winter, Harrisburg Patriot News. David, please go ahead.
Thanks again. There was a study that came out of Israel recently, got a lot of attention. I know you'll recognize the one I'm talking about, and one of the most newsworthy findings was that people who had immunity from natural infection were actually less likely to be hospitalized. I'm wondering what the UPMC doctors think regarding the validity and the implications of that study, and does it change your recommendations in any way? Thank you.
Dr. Williams.
Yeah, thanks for the question. The study you're talking about was not a controlled, it was sort of a retrospective analysis. I think there are no, what would be the ideal head-to-head trial of let's take 100 people with natural immunity and 100 people who are vaccinated and watch them and see what happens. And that's not going to happen because the world doesn't work that way and COVID changes too fast. What we do know are several things. Number one, vaccines induce more potent and more broadly reactive antibodies in general than natural immunity. Two, while people who are naturally infected do make antibody responses, the quantity and quality of those antibody responses varies widely. And the vaccine, everybody who's vaccinated essentially, except the immunocompromised, makes a very good, robust, and broad antibody response. Third, if somebody has natural immunity, let's say from being infected last year, that's not Delta. And we've talked about how variants can escape immunity. We actually don't know if somebody has antibodies in their body left over from having COVID last year, how good are those going to be against the current variants? And we know that vaccine-induced antibodies last a long time and are effective against all the variants so far. So somebody, in fact, who's had vaccine previously, somebody who's been infected previously should still get vaccinated. One of my 4 children had COVID last fall, a high school student at the time. She still got vaccinated when the vaccine was eligible for her age. I want her protected the best possible, and that's vaccine.
Next question comes from Joel Natalie from TalkErie.com. Joel, please go ahead.
Thank you. Again, as a follow-up, we're getting a lot of questions into the radio station about antibody testing and the lack of availability of that. Do you think that antibody testing will become part of the treatment plan here forward?
No.
Go ahead.
The standard antibody tests are a very crude measure of your immune competency for being able to be protected from a subsequent infection. And so the only test that would give a comprehensive assessment of one's protection are in fact very complicated and nowhere near being any kind of test that would be rolled out in routine testing. And that's why it's currently not recommended as any kind of standardized way for trying to assess whether you're protected.
Okay, next question, Paul Goff, Pittsburgh Business Times. Paul.
Yeah, hi. Thank you very much for taking another question. Are you seeing any, what's the supply of monoclonal antibodies? I've seen, obviously, that other parts of the country have seen an increase in them recently with the Delta variant. Are you, what's the supply at UPMC, and are you seeing any decrease in that because of patients, it going to other parts of the country where it's perhaps needed to?
Right. So with every aspect of COVID, whether it's treatments or testing, you usually need the product itself, the equipment to deliver it, and the people to deliver it. The product itself, monoclonals, we are totally fine for supply right now. It's certainly true that, as we've already alluded to, our hospitals are busy, and so we can be stretched on capacity, but we are finding a way, and we're managing capacity right now, and we're not short of drug supply.
Okay, thank you, Dr. Angus. Thank you, Dr. Sakrowitz. Thank you, Dr. Williams. That's all the time we have for today. Thank you for attending. In about 45 minutes, we will email media attendees a link to download high-definition footage of this entire press briefing, which we encourage you to use in your news reports. Any reporters with follow-up questions, please contact our UPMC Media Relations Department at upmc.com/media, and please remember to follow @UPMC News on Twitter for frequent updates. Thank you very much.